Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today, I am going to discuss a case of dyslipidemia as part of integration of biochemistry and early clinical exposure. So, there is a history. An 8-year-old boy with recurrent episodes of abdominal pain, especially after fatty meals. He had an episode of acute pancreatitis. That's a history. General examination showed eruptive xanthomas. Here you can see these raised lesions, the extensor aspect. So here is a patient with recurrent episodes of abdominal pain and eruptive xanthomas. His eye examination showed this is what is called lipemia retinalis. That is, you can see the milky colored arteries in the retina. This is what is called lipemia retinalis. So, this lipemia retinalis usually occurs when the triglyceride level is very high, usually more than 1000. So, indirectly, and the patient has got pancreatitis. Again, now we can correlate acute pancreatitis and lipemia retinalis suggests that this patient has got a hypertriglyceridemia. And this is the serum. Serum shows milky plasma. So this is called a lipemia. Again, lipemia is a feature of hypertriglyceridemia. This is the hemolyzed sample, and this is the normal serum, and this is the blood. So patient has got lipemia retinalis, plasma is lipemic, and has got recurrent pancreatitis. This is the lipid profile. You can see the patient has got a total cholesterol is increased, and you can see the triglycerides are very high, 2000. HDL cholesterol is decreased. Normally should be more than 40, it is 25. His LDL cholesterol is near normal or even less than normal. 130 is the serum amylase is elevated and lipase is elevated, indicating pancreatitis. Already mentioned about the plasma, which is milky or lipemic. So, what is this condition? This patient has got a hypertriglyceridemia and is a young patient, and his triglyceride level is very high, more than, or here it is 2000. This is consistent with the diagnosis of familial hypertriglyceridemia or familial chylomicronemia syndrome. This comes under the type 1 hyperlipidemia Frederickson's classification. It's an extremely rare autosomal recessive disease, and the mechanism is deficiency of lipoprotein lipase LPL or the cofactor apolipoprotein C2. So this is the biochemical basis. So in the Frederickson's type 5 also you get a hypertriglyceridemia, but usually the triglyceride levels are somewhere around 500, more than 500. You will not get this much, and this usually occurs presence in the adult life. So now we go into a little detail in the physiology of lipids. After a heavy meal or a meal with fat, the dietary fats are packed into chylomicrons in the small intestine. Chylomicrons travel through blood and deliver triglyceride to tissue via lipoprotein lipase. Lipoprotein lipase is anchored to the vascular endothelium and needs ApoC2 as the cofactor. So this is what we should remember. So if you take the chylomicron, so this is the chylomicron which has got Apo B48. It has got Apo A and ApoC2. This is rich in triglyceride, some amount of cholesterol esters and phospholipids. So this is the mature chylomicron molecule. So the most important apoprotein is 48. So this is passing through the blood and in the vascular endothelium. So this is the vascular endothelium. There is a enzyme, the lipoprotein lipase. This lipoprotein lipase needs the cofactor C2. Only when the C2 is attached, LPL will get activated. So if there is a deficiency of C2 or a deficiency of the lipoprotein lipase, the triglycerides cannot be split into fatty acid and glycerol in the tissues. So the chylomicrons are carriers of exogenous lipids, especially triglycerides, through which the triglycerides are transferred to the muscles and fat tissue. And in the blood vessels, the lipoprotein lipase is the one which split the triglyceride in the chylomicron. When there is a deficiency of C2 apoprotein, that is, this is deficient, this cannot activate LPL, and so what happens, the triglyceride cannot be split. So hypertriglyceridemia due to increased chylomicrons can occur in two situations. One, the C2 deficiency or the LPL deficiency. So this is the picture of the chylomicron. So here you can see the B48, which is important. This is a specific apoprotein of the chylomicrons. There is some amount of A1 and this is the C or C2. The C2 is the one that activates, and inside you get some phospholipids, free cholesterol and cholesterol esters. The most important component is the triglycerides. Hope the structure of lipoproteins is clear. The chylomicrons contains ApoC2, and C2 is the one that activates the lipoprotein lipase. So here you can see the C2, the ApoC2. This activates the LPL in the vascular endothelium. So the chylomicron is the triglyceride-rich apolipoprotein that carry the exogenous lipids. So here you can see the modified picture, which has already been explained. Remember that B48 is the apoprotein of chylomicron. ApoE is needed for it is donated from the SDL to the chylomicron for uptake by the liver. And C2 is the one, is the very important, which activates the LPL in the vascular endothelium. So today we have discussed about the Frederickson's type 1 hyperlipoproteinemia or familial chylomicronemia syndrome. It usually presents in the young age and very high triglycerides. There is more than 1000, 2000, etc. is the feature. Presents with pancreatitis and eruptive xanthomas. Let us see what happens to the chylomicron. That will be discussed in the next session. So this is in the intestine, the chylomicrons. It goes to the tissues. It is from where the triglycerides are removed and you get the chylomicron remnant. The chylomicron remnants are taken up by the liver. In the liver, it is recycled as the VLDL. So you can see the VLDL. The fate of the chylomicron and the VLDL will be discussed in the next session. Hope this was useful to you. Stay tuned. Thank you.